good evening here in Manila. Thank you so much for being here with us. Our tonight's speaker would be one of the best, Dr. Ferrari.
Thank you very much for joining us tonight for this session for continuing education by Rhein83. And we are happy to be joined we are very honored to be joined by a world-renowned speaker on implantology and prosthodontics. So our speaker for tonight is a graduate from University of Bologna for his dentistry course, and has took up also his further studies in implantology from the same university, as well as a postgraduate course in implantology from NYU. And he's currently a consultant for Rhein83 since 2015, and has been doing a lot of collaboration projects with Rhein83 in development of implant and prosthodontic solutions. So without further ado, please welcome Dr. Emiliano Ferrari.
Good evening to everybody. I'm very happy to be here, and we will spend together 1 hour talking about removable rehabilitation on root and on implant. First of all, thanks for your time, and feel free to make all the questions you have. I'm here to give you some answer and to share with you my daily experience. So when we talk about removable rehabilitation, the first things we have in mind is a denture. Denture is the easier, cheaper, and faster way to realize a removable rehabilitation. And what's the problem related with the denture? The problem is the stability, because you know that we have a lot of factors that can improve the stability of our denture. But sometimes all those factors are not enough to have a good results. We have different family of factors involved in this searching of stability. And the most important are the interfacial forces, so those forces related with saliva. And more important, maybe, the factor related with oral and facial musculature, because we can improve the stability, changing the shape of our denture. So we have to take care about the position of the teeth in the neutral zone, and we have to take care about the correct shape of the polished surface. There's a lot of rule to describe how we can have better stability. And these rules are related with the shape of the denture. But what can we really do to have better stability is to improve the retention. And retention is a characteristic of overdenture. So overdenture is something better respect the denture, because we have not only the stability given by the correct shape of the denture, but we also have retention. Retention and stability are two different concepts, because we can have stability with the correct shape of the rehabilitation, and stability is the position of our denture to the lateral movement. But we can search also retention, and retention is the opposition to the vertical movement. But to have retention, we have to introduce some element, some retentive element, to improve the retention itself. So overdenture is a complete or removable rehabilitation that is supported both by mucosa and by some remaining natural teeth or implant. So if we have enough remaining natural teeth, we can work on root. But if we have not remaining natural teeth and we have enough bone, we can use implant to have the same kind of results, the same kind of rehabilitation. When we talk about overdenture on implant, we have two different families of overdenture. First of all, the tissue-supported overdenture. Those kind of overdenture use implant only for the retention. The second family are the implant-supported retention. So in this case, implant help us not only for the retention, but also for the support of the rehabilitation. So implant-supported rehabilitation use bar and give us results that are the same of fixed rehabilitation, with the benefit of better oral hygiene. So different kind of attachment and different kind of final results. When we talk about attachment, we have to introduce the concept of retention. Because first of all, in history, we had friction kind of attachment with rigid material. But elastic kind of attachment are better because introducing also the concept of vertical resilience. So our response of our attachment that it's similar to the response of soft tissue. So something that stays better in the oral environment. And those kind of attachment distribute elastic material for the retention that are easy to be changed. So we can renew our attachment just changing the elastic female. And that's a very interesting concept. The first attachment introduced in the market with this concept is the sphere. And for a long time, the sphere was the best kind of attachment. Nowadays, the sphere, it's also a very good kind of attachment, but there's something a little bit different that can save the benefit of the sphere and can introduce new benefit. But talking about the sphere, that it's the core business for Rhein83 for a long time, we have to understand that the sphere can be used in a lot of ways. So what are the sphere attachments available on the market? First of all, two different sizes, normal and micro. Normal sphere is the bigger and give us better retention, because the bigger is the sphere, the bigger is the retentive area. But in some cases, when we have not enough prosthetical space, we can use microsphere, who give us retention, saving some space. And all those kind of sphere, so micro and normal, are available both for root and for implant. And talking about natural teeth, so talking about root, we have different kind of option. We have direct post that can be directly cemented in our root, or we have castable solution. The difference between direct post and castable solution is that when you use castable solution, you can change the position of the retentive parts. So you can change the position of the sphere, respect the X of your root. And that's very important when you have to manage some root with divergency. Same thing is for the implant. We can use castable solution or direct screw solution. So same option for root or for implant. There are also another line of sphere that are called flex. In this case, the retentive part, so the sphere, have a little movement and give us the option to manage bigger divergency on root or on implant. So on the same way, when we talk about root, we have direct post with flex sphere or castable solution. And at the same way, we can work on implant with direct solution flex. So that's all the option we have to work with the sphere. Why it's important to manage divergency between implant or root? It's important because the sphere can help you in give retention also when you have divergency between your element. But if the sphere doesn't work in the correct way, so according with the eggs of introduction of your rehabilitation, you can damage the sphere. So it's very important to save the activity of the sphere during the time to use those sphere in the correct way. So as I told you, first solution are direct pivot that are available pivot block or spheroflex. So with fixed sphere or removable sphere. Those are economical solution, very easy to be used, and can be intended as provisional or final solution. We have a different benefit when we use it in a provisional way or in a fixed final solution. When we talk about the direction of our implant or our root, it's very important to use the sphere in the correct way. So there's a tool that can help you input the female parts in the correct position. So we have some directional rings on 0, 7, or 14 degree that can be used to let your sphere working according with the eggs of insertion of your rehabilitation. Same things for the spheroflex. And when we use the spheroflex, we introduce a sphere rotation of 15 degree when we talk about two implants. So we can improve the 28 degree of correction of the normal sphere with more 15 degree. On that way, we can easily correct divergency until 43 degree. When we have bigger divergency, respect 43 degree, we can use the castable sphere. And castable sphere can be managed to change the position of the sphere respect the eggs of your root or your implant. Castable solutions are available both for direct use or with pre-prepared sphere with a surface treatment. So you can directly cast your sphere, or you can cast a device to bond your sphere and maintain the surface treatment of the sphere. This treatment gives you the option to have a sphere who work better during the time, who save the retentive area during the time. First of all, I want to share an easy case in which I've used the sphero block pivot for temporary use. Is a case of a patient who desire a fixed rehabilitation in the upper jaw. So I have to take out the teeth to leave the space in the bone to put my implant. But first of all, I want to deliver to my patient a provisional denture, and I can use 2 remaining natural roots to have retention during the time of healing of the bone. So to do that, I have to remove the hopeless teeth and to treat the canine that I can save. Now, I can prepare some retentive parts on my pivot and cement the pivot on the root. On that way, I have an easy and economical way to give retention to the provisional of the patient. On that way, I can take the provisional denture, take out the palate, and use my root for the retention. that's an interesting option to use those economical pivot to give retention of a provisional solution. After that, when I'm ready to put my implant, so after the healing of the bone, I can take out my root with the element of retention and put my implant. After the position of the implant, I go with the usual way for an immediate loading and deliver to the patient my fixed rehabilitation. So also in an interesting case of immediate loading on implant like this, I can use those pivot to improve the retention of the provisional for my patient during the healing. So it's something that I can give for more comfort to my patient with an economical solution. When I want to deliver to my patient something better, something that can stay during the time, maybe the correct solution are the castable sphere. In this case, I have to use root with long time survival provision. So in this case, I have to prepare my root, to prepare the space for the post, take an impression, and after the works up, so after the final, after the identification of the final volume of my rehabilitation, I can design my sphere. So in this case, I have different prosthetical space in the position of the incisor, respect the position of the canine. So I choose microsphere, the red one, for the incisor, and normosphere, the canine, for the canine. Very important is the position, the choice of the position of the sphere. And I can check this position with an instrument, a parallelometer, to put those spheres according with the eggs of insertion of my denture. On that way, I can prepare my casted post with different volume of the sphere, it doesn't matter. I can prepare a metal reinforcement and I can cement my post on the root. On that way, I've got casted solution with long time survival provision, okay? In some case, I can also use both the solution. It doesn't matter, that nothing changed. The element of retention is the same, indirect post or casted one. So in a case like this, in which I have different kind of root, so in the lower jaw, I've got very important root, canine. In the upper jaw, I've got only few incisors. So I'm not sure about the life expectancy of my root in the upper jaw, but I can save it. I can save it for a few times, because sometimes you can have benefit saving root, also to improve proprioceptivity sensitive of your patients. So also if you think that those root doesn't survive for a long time, it's interesting to maintain this root using economical post to improve the proprioceptivity of the patient. So in this case, different solution for the upper and the lower jaw. In the upper jaw, on the incisor, direct pivot. In the lower jaw, castable pivot. So the same way you have saw in the last clinical cases, if you want to use casted pivot, you have to take an impression and to prepare your casted post according with the available prosthetical space and according with the eggs of insertion of the rehabilitation. So at the end, you can cement both direct post or casted post. And as you can see, you have the same retentive area, both for direct economical pivot or for casted solution like this. Okay, so it's very interesting to take a look to the results in which in the lower jaw you have the sphere on the same direction because you can change the position according with the eggs of insertion of your denture. In the upper jaw, of course, the position of your pivot is related with the direction of the root. That's the most important difference between the upper solution and the lower one. Okay, and that's the final result. So that's all about the sphere. Everything you can do with the sphere can be done on implant or on remaining natural teeth. The evolution of the sphere is an attachment who is called Equator. The idea is save the same retentive area of the sphere, but saving some prosthetical space. So cutting the head of the sphere, you can maintain the retentive area under the equator, and you can remove a part of material, and on that way save prosthetical space. So the first idea of the equator was to be used as element of retention for direct rehabilitation. But another interesting option of the equator is the threaded internal parts. So as you can see, you can use the equator with the external parts for direct overdenture, or you can screw something inside the equator because you have a threaded part, like the multi-unit abutment. So for that reason, you can use the equator to screw a bar, and you can use the same attachment for direct rehabilitation, so soft tissue supported overdenture or implant supported rehabilitation. Same attachment. In the first case, you will use the external parts of the equator. In the second solution, you will use the internal part of the equator to screw your bar. At the same way, you can use the equator as a multi-unit abutment for the fixed rehabilitation. But that's another topic, maybe another webinar to explain how to use it for fixed rehabilitation. So when we use the equator as a sphere, so as an element of retention, they work like this. So the external part gives us the option to have retention. And we can correct until 30 degrees between two implants because of the elasticity of the female. But when we have to manage bigger divergency, respect 30 degrees, we can use castable solution. So in this case, we have to customize an abutment with the castable line of the equator, and we have a two-piece abutment with a screw in the direction of the implant, changing the position of the retentive area. So in that way, you can correct all the divergency that you want using direct screw abutment on your implant. Those abutments are intended for a lot of use. We can use it for natural teeth, or we can use it for direct overdenture on implant. And at the end, we can use it, as I told you before, to screw a bar. So to realize a bar supported overdenture, screw it on those abutments. Why it's important? Because to realize a bar direct screw on the implant, it's really difficult. It's difficult to have enough passivity. But there's a system who is called Seeger bar, who give you the option to realize the bar with a very high degree of passivity, screwing the bar on the equator and not directly on the implant. But I will show you later how to do that. Now we can take a look to some clinical cases just to explain the different options we have to use those kind of attachments. First of all, a case of hopeless teeth in upper and lower jaw. In this case, we have a patient with the final treatment plane of 2 denture. But if you take a look to the structure of the root support, maybe you can identify some root with interesting portion of earth structure. So we can choose to save some of those roots in the mandible to improve the retention and give benefit to the patient. And you can do that with the same cost of a denture, because those posts are really economical and very easy to be used. So they don't need too much time chair side to be used, and it doesn't change the cost of your treatment plan. So in this case, we can save 4 roots, the canine and the lateral incisor, after the extraction of the hopeless teeth. You have to do endodontic treatment and to prepare to reshape the internal parts of the root to bond your pivot. So after the healing of the soft tissue, you can bond your pivot on that way. It's very important when you use this direct economical pivot to put a little bit of cement on the dentine of the root, because you know that these parts of the root, it's easy to be damaged by caries. So for that reason, when you cement your post, take care about positioning a portion of cement also on the exposed parts of the root in the oral environment. This is a problem that you don't have when you use castable solution, because when you prepare a casted post, you can protect your root with metal. But in this case, the only things that those attachments give you is the retention. So to protect the root, use your cement. And when you are ready to deliver your final rehabilitation, you have 2 options. Your lab can give you the attachment, the female of the attachment, direct inside the denture. Or you can fix your attachment in mouth. So in this case, your lab have to prepare your denture with the hole to cement the female directly in mouth. When you use direct pivot, as I told you before, maybe you can face the problem of divergence between the element of retention, because the position of the element of retention is related with the direction of the root. So in a case like this, when you use direct post with little divergence, you can manage the problem of the divergence using a device that is called Smart Box. Smart Box is a different kind of female. So it doesn't change the equator, change the structure of the female. So you have a device that it's done by 2 different parts, usually. So the metal house and the plastic female inside. In this case, Smart Box is done by 3 different parts. You have the elastic female, you have the metal house, and between the elastic female and the metal house, you have a moving device who give you the option to couple the equator with the prosthesis, saving the imaging of the elastic parts. And this device is called Smart Box. It's just a different kind of female. in this video, you can understand how it works. So we have gold, designed in gold, is the metal house, and a rotating device inside that can move during the insertion. So if you have right implant, it works at the same way of the usual female. But because of this option of movement, it can help you in the insertion when you have divergence. Because on that way, the movement of the smart box give you the option to save the integrity of the elastic parts. Because the elastic parts work always in the correct way. In this video, you can see how it works. So the external parts, the metal house, stay always in the same position, but the elastic part change according with the divergence of the implant. So that's an easy and economical way to manage divergence between root. Because as I told you before, you can do the same things with castable solution, but castable solution are a little bit more expensive. So you can use castable solution when you have very strong root with a long time expected of life. When you want to save some root and you want to do an economical solution, maybe smart box is the best choice. In this picture, you can see the different metal house between standard attachment and smart box. The silver one is the standard attachment, the gold one is the smart box. As you can see, the only difference is that the diameter of the smart box is a little bit larger. Because, of course, you need the space for the device who give you the movement. Okay, so the only difference is the shape of the diameter. Another difference is that you can choose different color of elastic part to have different retention. You can see in the Rhein83 catalog that we have different color of elastic part. So we have yellow, pink, white, and violet. And different color means different retention. When you deliver your rehabilitation, as I told you before, you can choose to have your attachment directly from the lab, or you can put the female in mouth. When you use the smart box and you put the female in mouth, you have to use this black cap. Black cap are working cap, little bit larger respect the yellow one, just to protect the space of the movement. Because after this slide, I will show you a video to explain how to fix in mouth the female. But when you fix in mouth the female, you have to do that using acrylic. So this black larger cap protect the tool from the acrylic. After the fixing of the female in mouth, you have to remove the black cap and put the yellow or pink or the one you prefer. So as you can see, at the end, you have same kind of attachment. The only difference is that the black cap must be used to fix in mouth directly those attachments. So this is the final results. As you can see, we have enough root supports. We can expect that those roots will survive in mouth for a few years, but it doesn't matter how much because this is a very economical solution. So, how to fix in mouth the female? First of all, you have to understand why you have two different options. The first option, so have your rehabilitation with the female prepared by the lab, it's easier for you because you don't have to work chairside. But you have to understand that when your lab put the female in the denture, in the overdenture, they work on a gypsy model. Gypsy model have no the same resiliency of the soft tissue. So if you put the female directly in mouth, you can do that, saving also the resiliency of the soft tissue. Because when you put your overdenture on the tissue, you can manage the correct position according with the resiliency of the soft tissue. That's why my favorite option is to put the female by myself. I don't like to take the impression of the equator and have the rehabilitation with the female directly positioned by the lab. I prefer to have my rehabilitation with hole in which I will put my female. And how can I do that? In this video, you can understand. So here we have two equator. We just have to protect the equator with a plastic disc and fix the female. Now we have to prepare our denture with hole and check with a fit checker if there's enough space. So now I go in mouth, I check if there's no interference, I remove interference, and I prepare my hole. Now I put a little bit of acrylic, I go in mouth, wait for the curing of the acrylic, and at the end, after a few minutes, I've got my female inside the rehabilitation. I remove the excess of acrylic, polish, and deliver my rehabilitation. That's the way to fix the female direct in mouth, saving the response of the soft tissue, saving the resilience of the soft tissue according with the resilience of your attachment. Okay? Another case is same things but on implant. So you can do the same things using the same attachment also on implant. But what's interesting in this clinical case? The interesting things is the starting situation with a denture in the upper jaw and hopeless teeth in the lower jaw. Hopeless teeth means that in the RX, you can see that all those roots are must to be extracted. But maybe we can save some root for the provisional time. So the final project is put implant and realize overdenture on implant. But if we have some root that can be maintained for a few months, we can use those roots to give benefit to our patient during the provisional time. So what we have to do, same things of the last clinical case. We took out the hopeless teeth, we prepare the root, and we cement the post. That's very fast option, very economical solution. And now we can deliver the provisional to our patient and wait for the healing of the bone to put my implant. When I've got healing of the bone, I put my implant and I maintain the root to have retention and to save patient from the pain during the chewing, during the osteointegration of my implant. So you can see in this picture that I open my flap, I put my implant, I do my suture, waiting for the healing, but in this period, I can have the help of this root to have retention of my provision. After a few months, after the osteointegration of the implant, I can take out my root, screw the attachment on the implant, and go with the final rehabilitation. To realize the final rehabilitation, you can take an impression of your implant, an impression of your attachment. So you will take the impression of the equator, not the impression of the implant, because there's a dedicated line of transfer and a dedicated line of analog to work directly on the abutment equator. You don't have to take the impression of the implant. You work directly on the equator. And you can do that in analogic way or also in digital way. If you prefer, you can take intraoral scan or analogic impression. On that way, you realize your master model, you realize your waxing, and go until the final rehabilitation. An important things to take care about is the realization of a metal frame. Why? Because when you use those attachments for direct retention, during the time when you lose soft tissue, those elements of retention can become element of fracture. Because when after the year you lose the correct support of the soft tissue, those elements of retention can create parts of much force. So those positions can be element of fracture. So for that reason, when you use those attachments for direct rehabilitation, the things to do is realize a metal frame. To realize a metal frame, there's a line of castable element. So it's very, very easy, very, very fast for the lab, and of course, economical, because everything is very easy and fast, so economical. It doesn't change too much the cost of your final rehabilitation, but it's very important to save the life of your denture. So when you use those attachments for direct rehabilitation, realize a metal frame in a castable way or digital way, as you prefer. Casted or laser melting, it doesn't change. It doesn't matter. But realize a metal frame. It's very important to realize the metal frame, the less material you have. Because sometimes we think we have not enough space, so I avoid the realization of metal frame. It's a mistake, because the less prosthetic material you have, the more you need the metal frame. And it's possible to realize this metal frame very thin. So also if you have little prosthetic space, realize a thin metal frame. And this is the final rehabilitation delivered in mind. Okay. Last option you have to use those attachments in removable rehabilitation is the bar. So, as I told you before, bar is a solution with the same performance of fixed rehabilitation. Because when you have bar-supported removable rehabilitation, you have no movement, you have less cumbersome solution, so you have the same results of a fixed rehabilitation with two benefits. First of all, easier oral hygiene for the patient, respect fixed rehabilitation like Toronto Bridge, and a removable rehabilitation with acrylic parts that can give you help in the support of the soft tissue. So specifically in the upper jaw, when you need the support of the upper lips, a removable rehabilitation sometimes is better respect a fixed rehabilitation. So in this case, I had a patient with a denture in the lower jaw, and he came to my office for fixed rehabilitation. But we take care about the bone available, and the bone available was only in the anterior portion. So I cannot to put my implant in a distal way as I prefer for fixed rehabilitation. Second consideration, we need lip support. So in my opinion, in this case, removable solution is better respect fixed solution in the upper jaw for these patients. So first of all, check the profile of your patient to decide what's the better solution for him. Not only psychological reason, so fixed solution is better respect removable solution, because in some case, that's not true. In some case, removable solutions are better respect fixed one. So first of all, realize the waxing. First to put your implant, realize the waxing. Go in mouth, check the waxing, and if you are happy about that, that's the final volume of your rehabilitation. Inside this volume, you have to find the space for your implant. So the project of the surgery, the project of the position of the implant must be done after the realization of the waxing test, after the realization of the final volume of your prosthesis. Now you are able to put your implant. In this case, there's not too much choice because we have not too much bone. And the only position in which we can put our implant without augmentation technique is that. We put our implant, realize suture, wait for the healing, and after osseointegration, we go with the second surgery, and we put our Equator as a healing screw. So you avoid the use of healing screw, you do the second surgery and put the Equator as a healing screw. On that way, if you have a provisional, you can use the Equator to have retention of the provisional, waiting for the manufacturing of the final rehabilitation. Because you remember, the final rehabilitation will be bar. So bar screwed on the Equator. But waiting for the time of customizing of the bar, you can use those attachments for the direct retention of your provisional. And that's a very interesting option because you don't have to change your abutment. You put your abutment and you use it both for the retention of the provisional and for the retention of the final rehabilitation. Also, if we're talking about two different treatment planes, soft tissue supported provisional and implant supported rehabilitation on bar for the final rehabilitation. Okay, so that's the aspect of our Equator during the second surgery after the healing of the implant. And now in this video, you will understand why those bar is better respect a bar directly screw on the implant. Because as I told you before, to realize a bar direct screwed on implant is very difficult by the lab. But in this case, you can realize a bar with a high degree of passivity. So the more you can have passivity, the more it's easy to realize your bar. And how is it possible? It's possible because this bar is screwed on the head of the equator, and the passivity is full by an element, an elastic element that is called Seeger. Seeger is a plastic interrupted ring who fill the space between the equator and the bar. So that way you have passive bar, but fixed by the Seeger. You can see this is the bar, so passive, and here the Seeger fill the space between the equator and the bar. To put your Seeger, you will use a screw that fix the bar with the equator. And on that way, you can understand that you have really stable solution, easy to be realized because it's not directly screwed on the implant. That's why this bar, that is called Seeger bar, give you the option to easy manage the realization of a bar on implant. And you realize that directly on the head of the equator. So you can use the equator also for other solution, for the provisional. Okay. When you are ready, you can take the impression, different option, different kind of transfer, but in this case, we need the precision impression, so I like to use screw transferred on the equator. And in this case, we work in digital way. But it's not the only way. You can also weigh in analogic. You can also work in analogic way. It doesn't matter. Okay. My technician here work in digital world, but there's no problem to do the same things also in analogic way. So those are CAD/CAM realized bar. So first bar and second bar, milled the first bar and laser melted the secondary one. And in this picture, you can appreciate the difference between the final volume of the denture and the volume of the bar. So the bar is designed according with the position of the implant, but in this case, we have cantilever anterior and cantilever posterior. So very high degree of risk of fracture of our cantilever. For that reason, in this case, the better solution is removable rehabilitation. Same performance of the fixed without the risk of fracture related with the cantilever. And that's particular of the bar. You can see on the left the space that must fit with your equator and the Seeger who will fill the space between the equator and your bar. And that's all you need, your bar, your screw, and the Seeger. In this picture, you can appreciate other equator on the head of the bar. But you have to understand that here we have two different family of equator. First family are the equator screwed on the head of the implant, on which we will fix our bar. The equator that you can see in this picture are the one who provide this, the retention between the bar and the denture. So here we have used equator, but you can use also sphere, microsphere if you have not enough space. And you can put it on the head of the bar or on the anterior buccal parts or on the parietal parts. It depends on when you have enough prosthetical space to put the element of retention. Okay, so the design of the bar depends on the design of your final rehabilitation. That's why it's very important to realize the walks up before to design the bar. First of all, the walks up, after that, the surgery, and after that, the design of the bar, according with the final rehabilitation, of course. So that's the comparison between the size of the denture and the size of our bar. And in this case, of course, you can obtain results with same performance of a fixed rehabilitation, maybe with better aesthetical results. Because with the acrylic in the polished surface of your denture, you can also obtain the support of the soft tissue that you need. So in this picture of the profile of the patient, you can appreciate the lip support given by a removable solution. Okay? So that's all for this evening. That's the end of the lecture. I hope that it was enough to have an idea of all the solution. If you have some question, now I'm here. Thank you very much.
Thank you very much, Dr. Emiliano, for a very informative lecture.
Thank you very much.
To our guests, to our participants, if you have any questions, kindly write down on our chat box so that we can direct it to Dr. Emiliano. There's one question, Doc. You showed a case wherein you used equators for your provisional before transferring to your final prosthesis. How long would you recommend the use of the provisional?
It depends. It depends on if you have to wait for the healing of the implants. The times depends of the osseointegration. So something like 2 months for the mandible and 3 months for the maxilla. But sometimes you can maintain your provisional for a long time if you want to check the situation of the patients. Okay, so you maintain your provisional until you are sure that this is the correct solution for the patients. So at least 2 or 3 months, or sometimes also much more if you need much more time. That's why it's very important to have comfort during the provisional time, because if you have to stay with that something like 4, 5, 6 months, it's very interesting to give retention to the provisional with the attachment.
Thank you, Doc. There's another question, Doc, regarding the Seeger.
Yeah.
Is it something that you need to replace, or do you need the lab to replace it at a certain period of time?
No, because it's different respect the female of the removable rehabilitation, because the female in a direct overdenture working every time when you took out your denture, so 3-4 times a day. The Seeger working only when you insert the bar. When you insert the bar, the Seeger work, but after that, stay always in the same position. So you don't have to replace it. During the check of your patient, maybe 2 times in a year, when you check your patient, if you remove the bar to check the implant and you demage one Seeger, you can replace it. But you don't have to do that. It's not necessary.
Thank you, Doc, for that one. But of course, when you let's say do some maintenance on the bar, that's the time you have to replace it, right? Because you will already disengage the Seeger.
When you disengage it, if they are damaged, you have to change. But if they are not damaged, you cannot change it.
Otherwise, no need to touch, no need to replace. Yeah.
No need to replace.
Okay. Okay. Thank you, Doc.
See you.
Let's see if there's any other questions. So far, I think those are the questions that we have. And maybe if they have some fun, maybe our audience are, some of them are still absorbing our session tonight. I think there's a lot of new ideas that has been discussed. So if they may have any questions, you can just send it through the email or through us at Field Dent
Course.
Trading, or through
Course.
Ian, who is also our coordinator for Rhein83 here in the Philippines. For the doctors who are also online, just in case you have any inquiries, you can direct your questions to or contact us at Field Dent Trading. We are the dealers, the official dealer for Rhein83 here in the Philippines. Or you can contact again Ian Pajarillo, who is the Rhein83 coordinator here in the Philippines.
And,
Hopefully,
and
Dr.
if,
Emiliano, we would want to have you here in the near future. Maybe we can have a face-to-face
I will be happy about that.
seminar.
If you invite me, I will be happy to be there. I've never
Yes,
been,
yes.
so I will be very happy.
Oh, that's good. That's good. We'll try to arrange something, Doc. Otherwise, we'll see you in Italy. All right.
Fantastic.
All right. Good, good. So if there's any more questions, we will end the session now. Again, if you have any questions, please feel free to send it to us. And you can also check our website, the Rhein83 website. There's a lot of educational materials there. And all of the topics that were discussed today have materials that can be downloaded from the website. And we shall also be having a recorded webinar or recorded session of this one. So if you would like to request the recorded version, we can send it to you. All right. Good, good. All right. So again, good evening. Thank you very much for joining, and hopefully we will hear you. Join us again for our ongoing continuing education seminar. Thank you very much. Thank you very much, Doc.
Thank you very much.
Thanks,
Ciao, ciao.
everyone.
Merry Christmas.